So good morning, good afternoon and good evening to all. A very warm welcome on behalf of MYT and the Research Links series events team. We're very much looking forward to supporting you with today's webinar, Rising to the Challenge, Operational Research Results and Recommendations for NTD Programmes in the COVID-19 Context. I'll now hand over to Lee to begin to introduce you to today's session.
Thank you, Claire. Hello, everyone, and welcome once again to today's Research Link session ahead of our annual meeting of the Coalition for Operational Research on Neglected Tropical Diseases, or NTD. My name is Lee Hundley, and I am a technical lead with the NTD Support Center at the Task Force for Global Health. We're very pleased to present today's session, Rising to the Challenge, Operational Research Results and Recommendations for NTD Programs in the COVID-19 Context. The final session in the three-part series on Rising to the Challenge of COVID that is co-hosted by the Neglected Tropical Disease NGO Network, COVID Working Group, and Core NTD. Today's session has also been organized in conjunction with ICORDS, the Social and Behavioral Science Community of Practice. We will have two Q&A segments today during the session where you can ask questions to each of the presenters. I encourage you to post questions in the Q&A box throughout the session as the presentations are occurring. And also feel free to offer comments and have further discussion in the chat as well. We are looking forward to a rich conversation. With that, I will turn it over to LaShawn Benedict, the Community Manager for the ICORDS Community of Practice, who will tell you a little more about ICORDS and introduce the moderator for today's session.
Hello everyone, my name is LaShawn Benedict, the Community Manager for ICORDS Community of Practice. ICORDS stands for Improving Community Health Outcomes through Research, Dialogue, and System Strengthening. And it is a community of practice that serves as a platform for communication, collaboration, and knowledge exchange within the social and behavioral science research disciplines to ultimately address implementation gaps and current issues facing neglected tropical disease programs. You might be wondering, what exactly is a community of practice? Well, according to Etienne Wenger, a community of practice is a group of people who share a concern, a passion, or something that they do, and they learn how to do it better as they interact regularly. There are three characteristics to a community of practice. One is the domain, which is the shared area of interest. The second is the community, so that your members' interactions and knowledge sharing. And then the third is your practice, building resources and ideas to improve the domain of practice. To date, ICORDS has over 215 members from over 35 different countries. We also have 6 task teams currently available within ICORDS, such as social mobilization, health system strengthening, and one pertinent to this event, MDA restarts in the context of COVID-19. These task teams are meant to be dynamic in nature and based on need. If anyone has any ideas for task teams important to the social and behavioral science research disciplines, please feel free to contact me and we can work together to create a space for you. For more information on how to join as a member, please check out our website at www.icords.org or our Twitter page at icords_COP. Thank you for listening, and I'll now pass it over to Kevin.
Hi, everyone. It's a little dark over here. I'm in the Seattle area. It's about 6 in the morning. Welcome. My name is Kevin Bardosh. I'm a medical anthropologist at the University of Washington, and I got the honor to moderate today's wonderful sessions, or 2 sessions that we're going to have. I'm the co-chair of the ICORDS MDA Restart in the context of COVID-19 task team, along with Mary Nyamango from Kenya. And I'd like to just thank the organizers today, Core NTD and also the NNN network. And I think we have an exciting group of studies here that really speak to each other. And I'm really hoping and I'm anticipating a very stimulating and engaging discussion, despite the fact that we can't meet in person. But that's part of the challenges of COVID-19. So, and I'm sure we're going to be hearing about those today. So we have a series of 7 pre-recorded talks divided into 2 different sessions. first one, we're going to be hearing topics or discussion around MDA restarts themselves, the challenges during the pandemic, from case studies in Kenya, 2 case studies in Nigeria, and also a final one in Benin. And then we're going to go into a Q&A, our first Q&A of the workshop, and that's going to last for about 15 minutes. And then we're going to transition into our second session, which is going to be looking at, on the one hand, experiences of the pandemic for NTD programs in the Asia Pacific. 2 studies out of Nigeria looking at the experience of healthcare workers and also the willingness to work during the pandemic. And then we'll transition to our final Q&A. Now, each Q&A is going to last for about 15 minutes. And I encourage all of you during the talks themselves to post questions in the chat during the pre-recorded talks. And what we're going to do is we're going to grab all of those, synthesize them together, and then I'll read out a few of them during the Q&A itself, and then we'll have a back and forth during that time. So don't be shy. Post in the chat. We're keeping track of that. Yeah, and then the final point here is I'm going to introduce each speaker individually as we go through the session. So with that, that's my blurb here, and I'm going to start this session now with just a bio of the first speaker. So the first talk that we're going to have today is evaluation of MDA restart in Kenya. And this is by Miss Alice Sinket. Alice holds a master's degree in project planning and management from the University of Nairobi and a bachelor's in social science from Catholic University in Eastern Africa. She's currently executive director of the Africa Institute of Health and Development. She's been involved in the NTD assessments and research activities implemented by the Institute on behalf of the MOH since 2018. Before joining the Institute, she had worked for various institutions, including the Coalition of Violence Against Women, Children's Legal Action Network, United Nations High Commission for Refugees, and Child Welfare Society of Kenya. Alice has hands-on experience on qualitative and quantitative research, as well as in gender and child issues, which continues to be a major focus for the Africa Institute for Health and Development. So without further ado, here's Alice's presentation.
Good morning, good afternoon, good evening, depending on the time you have. My name is Alice Sinket, and I work for African Institute for Health and Development, which has been supporting the MOH for quite some time on neglected tropical diseases assessment and research. I'm going to make a presentation on a rapid assessment we've done in 2020 regarding the preparedness of the community for LF activities given the COVID context in Kenya. I'm making this presentation on behalf of the Kenyan team led by Dr. Miriam Yunzu Nyamongo, who was the PA for this study. We also had Alison Krentel, Dr. Sultani Matendechero, and Wycliffe Omondi from the MOH, Neglected Tropical Unit. So we did this study just to assess whether the communities will be willing to take part in the LF activities given the COVID context in the country and even globally. So what we wanted to look at is the perception of the community members on LF activities in the face of COVID-19. We also wanted to assess the willingness of the community members to take part in the LF-MD activities given the COVID-19 in the country. And we also wanted to know the CDDs and the front healthcare providers, their willingness to involve themselves in the program or to take part in the program given the COVID-19 pandemic. So in terms of the selection of sites, this study was done in Mombasa because of the high transmission of COVID-19, and also Kilifi was selected because of the low preparedness towards COVID-19 mitigation. And this came about from a study that was done by NTD program in 2020. And the two counties, we went to Jonvu in Mombasa because it was involved in the triple drug therapy pilot that was conducted in 2019. And Kilifi, we went to Magarini because it performed poorly in the MDA of 2019. And each of the sub-county, all the wards were selected to be included in the study. In terms of the people that were involved, in each of the county, we trained 10 arrays who are research assistants who are involved in the data collection. They were trained for 2 days. They also pilot tested the data collection tools before they embarked on data collection process. Data collection tools and techniques that we used, this was a cross-sectional study involving qualitative and quantitative data collection techniques, where we conducted in-depth interviews. We had an observation checklist that was implemented during the MDA campaign. We also had a short questionnaire that was administered to community members, and we also had an online survey that was also administered to community members. And this is just a summary. The table I'm showing shows a summary of the data collection tools that were implemented in the 2 counties that were involved in the assessment. In terms of processing of data, the quantitative was analyzed using the SPSS, while the qualitative data was analyzed manually based on the study themes. I'm going to give you the results of both qualitative and quantitative data. And the table I'm showing is a socio-demographic characteristics of the people that we interviewed in the both counties, Mombasa and Kilifi. So when you're asking people whether they were prepared to participate or they were willing to participate in the MD activities in Kilifi, a majority of them were willing to take part in the MD activity at 93.1. And even during qualitative inquiries, what was coming out very clearly was community members did not have a problem taking part in these activities. There are similar activities that were taking place. The only thing they requested is more social mobilization should take place prior to before the MD activities were taken to the community. And we're also asking them whether the CDDs they allowed the CDDs to visit their homes, and they did not have a problem since the majority of them in Kilifi at 98.7% were willing to have the CDDs or even front healthcare workers visit their homes during the MDA campaigns. And for Mombasa, where we're doing evaluation rather than an MDA taking place, a majority of the people are also willing to take part in the evaluation studies that the government was planning to undertake. We're also asking people, do you believe whether COVID is there? Are you adhering to MOH guidelines? And a majority of people were willing to adhere, and we can see there were hand washing stations at 90% in most of the places. In churches and religious leaders were saying even in churches, we had people social distancing and taking all other MOH guidelines. Although we had a very small fraction of people who are saying they've never seen anybody with COVID, and then they did not believe COVID was there, so they are not adhering to MOH guideline. In terms of the social mobilization channels that were recommended by the community in the context of COVID-19 before the MD activities, use of radio, use of community healthcare community leaders, and use of CDDs or CHVs was highly ranked as shown in that table. And during this assessment, we also undertook observation in Kilifi during the MDA, and I'm going to run through what we observed during the MDA. So the first thing we were looking at because we had a checklist, adherence of MOH measures during the MDA, especially by the CDDs. And what we saw, most of the CDDs were doing their best to adhere to the measures. They are using a plastic stick to distribute, a plastic spoon to distribute the drugs. They're also sanitizing their hand. They had a sanitizer ready. So that one was clearly seen during the MDA campaign. We're also looking at the willingness of the community to take part in the MDA, and it was very positive. The MDA was taken positively, although we had some areas that were not able to be reached due to poor terrain. We also had some people in some areas where they are saying they don't suffer from LF and they are not willing to take their drug. We also saw students, or in most of the households where students were outside the county, maybe they're in the university or in colleges, they are not targeted or they are not covered because they are not at home when the CDDs went to visit their home. They were outside their counties, so they were not reached. Also, the expectation of the community was very high during the MDA campaign. Some of them were expecting to be given money. Some of them are expecting to be given nets, and some of them are also expecting to be given surgeries, especially for those who already have LF. So the expectation of the community was very high. In terms of the behavior of the CDDs during the MDA, they were handling people very well. They were asking people for age before they dispensing their drug. And for children aged 2 years and very elderly people, they were requesting the caregivers to dissolve the deck for ease of swallowing. And also, the CDDs were well dressed, and they were explaining that at times this drug could have adverse effects. And hence, some of the people were saying, I took this drug last time and I felt asleep, so I'm not ready to take this time. But also, we saw during MDA, although some of them were practicing DOT, some of them were leaving drugs for people who are not at home during the distribution of the drug. So DOT was not 100% being practiced. Some of the CDDs were leaving drugs at home. In terms of recommendation, in case we want to do this MDA in the context of COVID, they say social mobilization should be done 2 weeks prior to the MDA. Use of community leaders or community-owned resource person is key. In case you want to reach the elites, use posters. In case you want to reach the illiterates, you can use pictorial posters so that you can reach everybody in the community. They say before also we use these people for sensitization and even distribution of drugs. They should be well trained before they engage in these activities. They say during the MDA, the local administration should be used or involved in enforcing COVID-19 measures so that the community is not at risk during this time. And the youth can also be used to sensitize people to observe the MOH guideline. I also say the frontline healthcare workers, they need to be supported, especially during this time of COVID, maybe give them insurance in term, to cover them against COVID, risk allowance, mental health counseling, and provide allowances, especially when they are doing contact tracing. Thank you so much for your time. Thank you.
Wonderful. What a great presentation, Alice. Thanks so much for that. Now we're going to transition to our second talk of the first session by Emily Griswold, and title of the talk is Evaluation of MDA Restart in Anambra State, Nigeria. Now, Emily joined the Carter Center's River Blindness, Lymphatic Filariasis, and Schistosomiasis program in 2015. She supports the programmatic and financial efforts of in-country programs. In addition, Emily has co-authored papers for journals, has planned surveys, and travels to the field offices to assess program needs. She conducts operational research studies and statistical analysis of program data and evaluates program performance. Prior to joining the Carter Center, Ms. Griswold worked for the Program for Appropriate Technology in Health, PATH, and supporting vaccine development technologies and the CDC's Division of Global HIV/AIDS. So without further ado, here's Emily's talk.
Good morning and afternoon. My name is Emily Griswold. I'm an Associate Director with the Carter Center's River Blindness, Lymphatic Filariasis, and Schistosomiasis program, together with Dr. Adamu Salau, who is a director of our program in Nigeria. We are presenting the results of our study preventing the spread of COVID-19 during MDA in Anambra State, Nigeria. For reference, Anambra State, Nigeria is located in the southern part of the country. There are 21 districts, which are known as local government areas. On average, the Carter Center supports MDA for 2 to 3 million people for a variety of NTDs, and the total population is just under 6 million. The objective of our study was to document the scope of and adherence to COVID-19 prevention and mitigation measures throughout Anambra State. We used a variety of methods. We conducted observations that were captured using electronic data. We also conducted interviews and focus groups with people throughout the health system and in communities. And we also compared the costs of supporting MDA during the pandemic as well as before. We undertook all of this work from December of last year through today. These are the results of our observations. Again, these were collected on Android tablets. We conducted 132 discrete observations at health facilities, house-to-house MDAs, and at community observations. We also observed 92 centrally distributed MDAs and 12 LGAs, as well as 70 trainings and 8 LGAs. We were unable to get observations in all 21 LGAs of Anambra State due to the timing of the MDA. Briefly, here are the locations of the observations, and you can see how they were distributed throughout Anambra State. During trainings, we noted that the mitigations and prevention measures of social distancing, hand washing, screening for symptoms, and maintaining airflow, such as ways of keeping training outdoors, those were well adhered to in almost every single instance. What didn't really occur very often was testing before training. Testing was not as widely available as one would have hoped. During MDA, we saw that nearly all CDDs were adhering very well to all the prevention measures. They completely understood them and undertook them in every instance, such as wearing masks, maintaining distance, and giving health education, and hand washing was also well observed. One thing we'd noticed did not occur very readily was the wearing of gloves. Gloves were not easy to find and were not readily available to most CDDs, as you can see in the picture here. When we observed MDA in the community, we noticed that most people were very able to wash their hands and were in fact eager to wash their hands frequently in the MDA process. There was some ability to maintain physical distancing, but we noticed that people weren't wearing masks regularly in the MDA. So the interviews and focus groups were conducted by MOH and Carter Center staff. These were recorded and then transcribed and analyzed. We conducted 48 focus groups, which were divided by sex and age, as well as 8 sessions with CDDs who were divided by sex. The key informant interviews were conducted with folks from throughout the health system. Some of our main focus group findings from CDDs, they noted that while they were happy to undertake the measures, they thought them very important. They noted that MDA took a lot longer and required more effort. They had a lot more supplies to carry. So one of the measures was that they had to use plates and spoons to distribute medications instead of their hands. That was more stuff for them to carry around. There has been over the years an increased emphasis on directly observed treatment, and this became even more important during this time. And then one of the mitigation members was a stronger emphasis on house-to-house distribution of medicines. All of this led to longer days and more frequent travel as they went back and forth to households to make sure that people were treated. All of this travel incurred extra costs to CDDs, and they also used their own money to buy notebooks, extra masks, extra sanitizer, and other supplies that they felt were necessary for MDA. This is in a background of costs rising in general in Nigeria during this time. However, as I said, they were happy to undertake the extra hygiene measures in particular, and they felt that coverage might have been increased. One of the reasons they thought that coverage might have been increased was that more people were at home due to lockdowns and from businesses being closed across the country. They also noted that the increased visits to households may have reached more people, particularly children. They did note that they needed to do extra sensitization and extra work to prepare people for MDA this time around. Part of this was because of persistent disinformation and misinformation throughout Nigeria that caused a lot of suspicion about drugs being distributed during this time. Our findings among community members were that most of them were very favorable and very eager to undertake extra hand washing. They thought the extra hygiene was very well appreciated. In general, people were well informed about COVID-19 as a disease, the symptoms, and its transmission, with some exceptions. But they did note that no one had any personal experience with COVID. It was considered a disease that was found abroad or in cities and not in their communities in general. I would note that malaria here is considered, it's often considered a catch-all symptoms of fever, chills, and body aches. Their sources of information about COVID were highly varied, such as TV, newspapers, social media, radio, health professionals, and friends, and church was a very popular source of information. They saw that, as I said, they saw the value in the extra precautions, particularly in the hygiene, and they thought that this was meaningful and effective. Our cost study looked at the costs of conducting MDA during the time of COVID, as well as before. The changes in costs that we observed were primarily due to the need to train people in more batches. So in order to reach the same number of people as before, we needed to conduct more trainings. We also noted increases in transport costs that were driven by social distancing, as well as by increases in costs that were seen overall in Nigeria through the pandemic. Here is a summary of the changes that we observed when we compared the costs from the two MDAs. We noticed that overall costs increased about 34%. These were primarily driven by the increases in the number of sessions that we needed to hold in order to meet our training and supervision goals, as well as the costs that increased for transportation. Costs in general rose during this time, and also we needed to recruit more vehicles and more motorcycles and other forms of transportation in order to maintain lower density of people on those forms of transportation. PPE was an entirely new cost to us, and although we had many donors that were very generous to support this effort, it is a pretty substantial cost to support PPE for the entire program in perpetuity. That is all for now, and I welcome your questions and feedback. Thank you very much.
Wonderful. That was a really interesting talk by Emily. What a nice figure there at the end with the breakdown of costs, increased costs, important issues that we'll hopefully pick up in the Q&A after these last two talks of the session. So now I get to the pleasure of introducing our third speaker, Ariana Means, who's an assistant professor at the University of Washington, where she specializes in implementation science and NTDs, malnutrition and child survival. And all right, so now we're going to hear from Ariana.
Hello, my name is Ariana Means. Today I'll be presenting the results of a multi-method evaluation of MDA restart in the context of the COVID-19 pandemic in Benin. I'd like to start by acknowledging our research team leadership pictured here. All of the work that I'm presenting today reflects the hard work of these individuals and many others not pictured here. The first confirmed case of COVID-19 in Benin was detected in March 2020. After a brief closure of schools and public events, including MDA, most activities reopened in June 2020. And to date, there have been just over 9,000 confirmed cases of COVID-19 and 113 confirmed deaths attributable to coronavirus infection in Benin. In July 2020, the NTD program in Benin, in collaboration with partners, developed a standard operating procedure for conducting MDA in community settings during the COVID-19 pandemic. This standard operating procedure, or SOP, draws from existing WHO recommendations, and it includes guidance about mandatory masking for CDDs, supervisors, and even community members, guidance regarding physical distancing and use of hand washing or gel prior to treatment, guidance for how CDDs can avoid direct contact with medications during distribution and avoid contact between participants and dose pools. And it also recommends that CDDs educate community members about COVID-19 during MDA. So the purpose of this project was to evaluate fidelity to the national SOP, to describe the strengths and challenges of implementing the SOP from the perspective of multi-level stakeholders, including CDDs and other NTD program personnel, and to assess differences in implementation costs driven by these adaptations to implementing according to the national SOP. Data collection took place in 3 communes in Benin, including both rural and semi-urban settings in March 2021. To address our first aim, we conducted observation of CDDs during implementation of MDA for onchocerciasis. CDDs were informed in advance that they might be observed, after which observations occurred at random. Observational data were collected on paper forms and entered into Survey CTO. Qualitative data were collected via focus group discussions, or FGDs, and key informant interviews. Key informant interviews were conducted with purposively selected individuals at national, commune, and health center levels using a semi-structured question guide, while FGDs were conducted with CDDs. Both FGDs and interviews were used to probe on and explain findings from the observational data. And we used rapid framework-based methods for qualitative analysis with coders based in Benin and in the US. And lastly, commune level costs associated with COVID-19 adaptations were collected via Ministry of Health budgets and entered into a standardized Excel-based spreadsheet. So a total of 349 CDD interactions were observed across the 3 communes, and pooled results from all 3 communes are presented here. In general, these findings indicate that very few COVID-19 precautions were followed. While most drugs were distributed outdoors, as you can see in the first column, 83% of CDDs did not practice physical distancing during drug delivery, as you can see in the second column. Furthermore, 71% of CDDs were not properly wearing face masks, and 87% of community members were not wearing masks at the time of distribution. Just over 90% of CDDs did not wash their hands prior to drug distribution. But on a positive note, there was very little unsafe congregation at households during MDA, which was observed at only 18% of households. The national SOP also recommended delivery of COVID-19 education during MDA. In this study, only 4% of CDDs delivered any messages about COVID-19 during treatment. Similarly, only 13% discussed ivermectin-related adverse events in general, and only 1% discussed how drug-related adverse events may be similar to COVID-19 symptoms. However, on a positive note, 84% of drug distributors avoided contact between participants and dose poles, as recommended by the national SOP, and nearly 60% managed not to touch the tablets with their bare hands during drug distribution. We conducted 37 focus groups and interviews to probe upon and expand our understanding of these quantitative findings. I'll be sharing 3 of the main themes that emerged from these data. So first, we found that there were many misconceptions and misinformation in the community about COVID-19, such as beliefs that COVID did not exist, that it was created by foreigners, or that CDDs and MDA campaigns were used to spread infection. CDDs observed significant stigma about COVID-19 in the community. For example, beliefs that individuals wearing masks are infected with COVID. One CDD noted that MDA delivery has never been as difficult as it is this time around. They also observed successful strategies for engaging with communities, such as strengthening partnerships with local leaders. Our findings also indicate differences in perceptions about the implementation of the national SOP amongst different stakeholders, particularly across levels of the program. For example, as evidenced by the juxtaposition of the quotes here, there are different reports of who was being asked to support procurement of protective equipment, varying from partners at the national level to health facilities reporting that they were being asked to provide soap and masks to CDDs directly prior to MDA. Lastly, CDDs appear not to have adhered to COVID-19 preventative measures, in part due to reasons outside of their control. CDDs reported in focus groups that they've not been provided protective equipment, and some procured it on their own. One CDD said, as we were trained and we were told the precautions to take, they did not give the equipment. Everyone managed with the equipment they have at home to protect themselves and do the activity. Lastly, the total additional costs associated with campaign adaptations across all 3 communes was $7,731 US, and costs were similar in each commune. The primary drivers of costs were additional supervision to support relaunch of MDA, as well as hand sanitizer procured specifically for MDA. So in conclusion, MDA coverage was high during this round of MDA for onchocerciasis, with over 80% coverage in all communes. But fidelity to COVID-19 SOPs was low across most indicators. CDDs reported that it was really challenging to deliver MDA, in part due to widespread misinformation about COVID-19 and MDA. And although there was an investment in procuring protective equipment for trainings and drug distribution at a national level, there's conflicting reports and some ambiguity about access to protective equipment across stakeholders at a local level. And we identified opportunities to continue to improve program delivery, specifically by focusing on CDD training to address specific myths and rumors and improvements to supply chains of protective equipment. So we'd like to acknowledge all of the participants who contributed to this project and the financial support received from Core NTD. Thank you for your time, and we look forward to your questions.
Wonderful, that was great. Thanks, Ariana. That talk really spoke quite directly to the methods used by Emily in Nigeria as well. So that was a great set of presentations. Now we're going to transition to our final talk of this first session, and that is by Dr. Luert-Lar, Evaluation of MDA Restart in Kwara and Kano States, Nigeria. Dr. Lar is a Nigerian medical doctor with a public health specialty. For the past 6 years, she has been the research manager of the Countdown Project, a multi-country and multidisciplinary research consortium that is led by the Liverpool School of Tropical Medicine and implemented in Nigeria by Sightsavers. In addition to the MDA Restart study, she has also led a study on the integrated case detection and referral for people affected by skin NTDs in Kaduna and Ogun states in Nigeria. She equally leads on the MDA Restart in Nigeria, and she's graduated with a master's in international public health from the Liverpool School of Tropical Medicine in 2019. So here is Dr. Lar.
I am presenting on behalf of the team that worked on the evaluation of mass drug administration, MDA Restart, in Kwara and Kano states, Nigeria. I'm sure it's not news to all of us that the World Health Organization suspended all MDA activities due to the pandemic in 2020. Nigeria stopped MDA in 2020 in April, and ESPEN and Core NTD supported countries to develop standard operating procedures, SOPs, for restarting MDA campaigns in April 2021, and Nigeria is one of these countries. Our study aim was to document the processes, successes, and difficulties in implementing guidelines to support NTD program restart and informing policy and program adaptations in other countries and future activities. We had 4 study objectives spanning from gaining insight regarding program challenges with adherence to new guidelines and SOPs, understanding barriers and challenges among community drug distributors, CDDs, in the implementation of the revised SOPs, including issues with enhanced CDD training. We also wanted to understand the community's perspective as it relates to the adapted MDA campaign in the midst of the pandemic. Lastly, we wanted to assess differences in implementation costs for adapted MDA approach. We worked in Kano State, northwestern Nigeria, and Kwara in north-central Nigeria. Within these 2 states, we worked in 1 urban and 1 rural local government area, LGA, and a facility per LGA was selected based on their proximity to the LGA headquarters. 1 was closer and 1 was further. COVID-19 cases are documented more in urban than rural contexts. Implementation of SOPs and the impact of COVID-19 would most likely vary by these contexts. We employed a mixed methods approach where we conducted pre and post MDA key informant interviews with stakeholders at the federal, national, and subnational levels. We observed using checklists the MDA process spanning from advocacies where stakeholders are visited and informed about the MDA process and its restart, and training of implementers. We also conducted CDD interviews and community interviews to get their perspectives and a costing spreadsheet to have an idea of the implications of costing and restarting MDA in the midst of the pandemic. 5 key themes emerged from our findings. In terms of the context of COVID-19, there were higher concentrations of cases in the urban locations. Multiple sectors of the economy, spanning between the health and the education sector, were affected, mainly due to national lockdowns. Initial fears of the pandemic existed. They lessened as the government prioritized resources for prevention and management of the pandemic. As the economy reopened, the communities became more positive in adhering to COVID-19 regulations, such as the wearing of face coverings. This quote further supports the impact that the pandemic had on the economy. Medicines distributions of 2020 were conducted in 2021. Multiple areas, including travel, personal protective equipment, PPE, and venue hire costs, were directly incurred by the program partners. Majority of the costs were linked to the provision of PPEs. The decision to restart MDA was collaborative between the federal, the state, and the lower levels. Although for the lower levels, this was not always the case, but they did not mind as they developed context-specific messages using town announcers and jingles to sensitize and mobilize communities about the restart of MDA. The quote on the right further supports this. In terms of the practical realities of restarting MDA, majority said that the adaptations to MDA training was successful. Due to the pandemic, time was taken to train implementers where pictorial learning aids were utilized. Preventive measures were also discussed. Majority of the implementers adhered to preventive measures. However, there were difficulties to maintaining social distancing, mainly due to small hall sizes and rescheduling initially outdoor trainings to indoor trainings based on weather conditions. House-to-house distributions were utilized for safety, seen as normal in the rural areas, although an adaptation in the urban areas, as in previous MDAs, fixed posts such as markets were also utilized. The challenges that the CDDs faced were similar to previous MDAs, such as high workload and out-of-pocket expenditure. However, for this MDA restart in the midst of the pandemic, the out-of-pocket expenditures were more, mainly due to additional purchases of inadequate supplies of PPEs. They also experienced discomfort with wearing face coverings. Stigma was also experienced. This quote speaks to the issue of stigma, whereas implementers wear their face masks, some households see them and start chanting "Corona, Corona," and they run away. This quote shows competing interests of the communities on the need for food or money as opposed to sharing medicines. Sensitization, mobilization, and COVID-19 led to higher acceptance in this round of the MDA. People with disabilities were also included. The reasons for refusal in this MDA were similar to previous MDAs. In male-headed households, where these household heads refuse the medicines, the other household members automatically cannot accept them. Some refuse to participate based on reasons shown in the table on the right. Youths and the elderly were among these groups, and their reasons were due to the perceived COVID-19 vaccines as the medicines that were distributed, the fears linked to COVID-19 among the elderly, and the lack of trust in the health system. The quote below further supports these findings. This MDA was more successful than previous MDAs, mainly due to higher recorded geographical coverage and the use of health information systems, which made reporting more effective and efficient. Improved planning, training, and coordination of MDA during the pandemic also contributed to these successful MDA outcomes. Similar contexts could benefit from this all-inclusive preparatory phase and context-applicable messaging. Challenges documented could be minimized and the successes leveraged upon. We want to sincerely thank the core NTD who funded the study, the Kano and Kwara State Ministry of Health, and the Federal Ministry of Health in Nigeria for their immense support. Thank you for listening.
Hello, everyone. Great. Thank you very much, Luwert, for that great presentation on MDA restart in Nigeria. So now we're going to transition into our first Q&A of the session. And then we have about 15 minutes. I have quite a number of questions here in the chat box and that I'm going to go through. I'm going to start with one for Dr. Laura. Is she online? I haven't.
Yes.
Yes. Okay. Great. Wonderful. So Adrian Hopkins is asked. Oh, sorry. This is actually a general question. Pardon me. There was a question for you. I was gonna. Okay. Oh, sorry. I meant to say this was a question for Emily. Pardon me. So, if Emily's available, there was a question from Oletin Omitola, and they say, thank you, Emily, for the presentation. The findings on hygiene practices during the MDA look impressive. Do you think this was similar for both the urban and rural areas in Anambra?
Thanks for the question. That's a really good one. I will defer if there were any differences in rural or urban areas to Dr. Adamu. What I can say is that the focus group findings and the observational findings, they really corroborate each other, that hygiene was really both well practiced, and also people really see it as staying clean and keeping their environment clean. They thought it really enhanced the MDA and also enhanced any sort of prevention measures that they were taking towards COVID-19 specifically. Adamu, would you like to speak to any sort of differences that you saw yourself?
Yes, let me just, hello?
Yeah, we
can hear you.
Yeah, okay, let me just add that hygiene is taken seriously in both rural and urban. You can also say that, yes, the urban, because the people are educated, the elites are there, and so you expect the urban areas to have a better hygiene situation. But in the rural areas too, especially hand washing, that in this part of the country, in Anambra, for example, in the east, most of our food are what we call swallow form. People don't eat with spoons. They don't eat with cutlery. They wash their hands and eat with hands. And you wash your hand before you eat, and you wash your hand after eating. And this has been the practice. The culture of the people here, you hardly go to any home even in the most elitist homes, people still use hands to eat, and therefore you wash your hands before you eat, and you wash after eating. And of course, when the COVID-19 issue came and hand washing was emphasized, of course the people were already used to it, and of course that also was went up high and has been maintained, and we saw that in both the rural and the urban areas. Thank you.
That's great. Thanks for that, Adamu. Now there's another question for the group here, for Emily and also for yourself. This is from Claire Dwyer, and she asks, do you think there is any issue with the Hawthorne effect, where people modify their behavior because they are being observed, like increasing hand washing? Did people know they were being observed? Where they didn't do something, like not many did COVID testing pre-training? Did you, the observers, point this out at the end and ask if there was a reason for this?
Let me respond by saying that it is possible that some people knew they were being observed, but I just want to say that the officer, whoever was observing, only went with a piece of paper or a tablet to put in his responses or observations, and of course they had no idea what the person was doing with the mobile phone, kind of. And so I don't think they knew they were being watched. I remember very well that we can say authoritatively that there was a lot of mobilization and public awareness, and therefore giving information to both the health workers and the public. And so we saw that, positive response towards observing COVID-19 preventive measures. And so, like I said, it's possible some knew they were being observed, but a lot of people wouldn't know, because the person that was observing only had a tablet, which was like a mobile phone you could hold and enter your observations. In terms of hand washing, like I said, the culture here for hand washing is high. Even in schools, you have hand washing facilities by wash programs, and most of the schools, if you visit, you see hand washing facilities. And like I said, hand washing is a culture here that people, would always adhere to.
Mm-hmm. Thanks for that.
As far as testing is concerned, other than using thermometer or using febrile condition in an individual, and also saying, please, if you have cough or you have high temperature or you have difficulty in breathing, let us know. And that is where we can stop. The other things, of course, individuals who presented with some symptoms are referred to the district COVID-19 committee, who will in turn move the individual to the state COVID-19 committee, where they have testing centers. And so we're not in a position to do that level of testing other than the simple symptoms of temperature, difficulty in breathing or coughing and all of that. So other than that, and of course in the state, we have noted that there are just a few testing centers in about 4 districts that are urban areas. And so individuals from the rural areas are taken by the district COVID-19 committees to the testing centers that are in the urban centers. And we wouldn't know what has happened. And all the figures of COVID-19 cases that are being reported, it's just a block. It's reported district by district, but you wouldn't know which are the locations that have the COVID cases to be able to say this community has high cases. I think that information is being retained for whatever reason that the government is trying to manage the information and all that. But that we do minor testing and all that. Yeah.
That's really insightful. Thanks, Adumu. Now, just a question here for yourself, Dr. Laura, in Nigeria, and this is actually to the group, but let's start with the Nigerian experience. Arian Hopkins is asking, was there any evidence or impression of a surge in COVID cases following the distribution in any of the programs? Wondering if you saw anything like that in your study areas.
Thank you very much for that question. From our own study area, we didn't really document that, and you can see there's an evidence for that. But as we mentioned from our findings, the concentration of the cases were more in the urban areas. And that could be attributed to the fact that there were more testing centers in the urban areas. People tend to congregate more in the urban areas and live more in the urban areas. So I think that's our feedback from Nigeria. Thank you.
Mm-hmm. How about in Benin, Ariana?
Yeah, thanks for the question. To my knowledge, there wasn't any surges after NDA took place. These data were collected in March, and Benin is experiencing a higher surge in COVID cases now than they were at that time, which I think perceptions of COVID risk and of NDA are probably linked in some ways to perceptions of risk of infection and prevalence within the country at the time. So I think it'd be interesting to revisit some of these issues now as the pandemic evolves in different settings. But to my knowledge, there was no resulting surge in cases after NDA.
And Alice, how about yourself in Kenya? Are you with us, Alice? Oh, maybe not. Okay. Well, I mean, that transitions quite well to a question I wanted to ask here, which was around risk perception, but then also the perception of the MDA program. So we've seen with all of these programs that there's an idea that coverage has increased this year because there's more attention to planning. There's more training that's been given to the CDDs and others. But I'm also curious if there's a change in perception of the medication. A lot of there's large different perceptions around the use of ivermectin for COVID, hydroxychloroquine, and other parasitic drugs, right? And I'm wondering what your study data has shown in terms of people's willingness to take the medication, possibly for other reasons and not just for NTD control. So I'm wondering if any of the speakers sort of came across data along those lines. Ariana, do you want to start? You're nodding your head.
Sure. Yeah, we did probe on this. We were observing onchocerciasis MDA to determine, we were interested in determining if there was changing perceptions of ivermectin. We didn't observe any changes in demand for ivermectin related to COVID-19. If anything, there was a bit more skepticism. And I think I mentioned in my talk that many CDDs felt like they do much more mobilization and assurances of safety than they normally did. So yeah, we didn't find a higher demand of ivermectin related to the pandemic in Benin.
Anybody else? Dr. Laura, I think I saw you also nodding.
Yeah, I think quite similar. Yeah, I think quite similar to Ariana, we didn't, but I can remember in a few of our data sets, some of the participants were mentioning the fact that after taking the medicines, ivermectin, of course, they seem to feel better. And there were some of them that were asking for more of the medicine and maybe having them more than once in a year. So I think that's the feedback from Nigeria.
Had people heard about the use of ivermectin for COVID? Was that something that people were aware of? Yeah. Okay. So they weren't saying, oh yeah, I would like to keep this medication, or there was no discussion around that. I'm just wondering.
Yeah, because sorry to chip in.
Yeah,
because there were this misinformation and rumors about ivermectin being used as a cure for COVID. And I think the CDDs actually confirmed the fact that individuals who were ivermectin naive in the past had come forward to ask for medicine to take. Maybe for our NTD program, but also because they think that it will cure COVID or prevent COVID in the event that they take. So there was the coverage was high in some of these, and part of the explanation would be that individuals that were naive for ivermectin now took the medicine and were asking for more, just like it was said.
Great, that's an interesting topic. So here's a question to the group by Nikhil Patel. They ask, looking at the additional costs for PPE to MDA programs, which we've seen with all the case studies, and then it looks like COVID-19 prevention will continue to be important for at least the next few years. What is the sustainability of the financial supporting for these precautionary measures in the future? Is this something implementing partners will continue to need to shoulder in terms of the burden of cost? Or are governments looking to include PPE costs in the future budgets?
The implementation of our programs are guided strictly by the COVID-19 protocols with the SOPs in place. And as long as we're going to operate according to the guidelines, we'll have to continue to incur costs. This is going to be a challenge, and we have noted to donors that providing PPE, at least to the CDDs and health workers who are the ones that are in the field, will continue to be there for us, and so the cost is what we'll have to bear. I know that government is also doing a lot to look at how they can sustain some of these, like testing, increasing testing centers, providing thermometers, infrared thermometers to many health facilities and so on. Will continue to be cost that both the partners and government will bear.
Yeah, and I think maybe to also add, I know that a lot of this has been donor supported, but from most of our findings, the CDDs were advocating for this to be something that both the government and the partners can take forward. And moving forward, not just to provide for the implementers, but also to consider the communities that we provide services for. Because if we protect the implementers that are giving it to the beneficiaries and the beneficiaries don't have it, then it's like we haven't won. So I think from what we're getting from our findings, the government is beginning to prioritize this because it's a reality that we have to live with. So there are counterpart fundings within the states, and I'm sure they're going to prioritize that moving forward. Thank you.
And Kevin, just to add to that, I think it's a really important question. And in addition to PPE, I think a common theme across presentations that there will be additional costs related to time as well, and the time it takes to deliver MDA during COVID, even from how many people you can transport in a vehicle to the added time it takes to do socialization or social mobilization around the campaign. So both supervision and time costs, I think, are also costs that will endure for the foreseeable future too.
That's correct.
I would wholeheartedly agree with Ariana that this is kind of becoming baked into how do we do our budgets and how we plan our programs going forward. It's not, it's a new paradigm in a lot of ways. So it's taking some time to work its way totally through. But I think that the thinking that we've had to do to make this work has been valuable.
Okay, well, thanks everyone for that great conversation. And I'd like to thank all of the speakers for this first session, and we're going to now transition into the second session of the workshop. So stay tuned. Thanks, everyone. So we have 3 more talks here in our second session of the workshop. We are going to start with a presentation by Dr. Claire Dwyer, who's going to be talking about, or the title of the presentation is Conducting NTD Control Activities in a Pandemic Experiences from the Asia Pacific Region. Claire is a postdoctoral research fellow in the NTD research group at the Kirby Institute, UNSW Sydney. Her main research focus is soil transmitted helminths and trachoma. Claire's background is in molecular cell biology, in which she holds a PhD. She currently graduated with excellence from UNSW Sydney with a dual master's degree in public health and international public health, specializing in epidemiology. Claire previously worked as a project manager and medical writer in the medical communications industry, and more recently as a researcher in the Eastern Cape of South Africa on a large longitudinal cohort study of adolescents living with HIV. So without further ado, here's Dr. Claire Dwyer's presentation.
So hello everyone, my name is Claire and I work in the NTD's research group at Kirby Institute at the University of New South Wales in Sydney, Australia. I'll be talking to you today about a project we've recently started to look at how the pandemic has affected NTD programs in the Asia Pacific region and how programs have managed to restart or continue in spite of the pandemic. So this project is funded by the Australian Centre for the Control and Elimination of Neglected Tropical Diseases, or ACE NTD. So a lot of work has been done already to look at the negative impact of the pandemic. For example, the NTD Modelling Consortium's work on forecasting the negative impact of stopping MDA on disease burden. So we'd heard a few anecdotal examples of how some NTD programs had used innovative approaches to restart or continue delivering their control activities in spite of lockdowns and other pandemic restrictions. And we thought it was important to document these in order to share best practice and learnings across the region. So this was the main rationale for our project. And we decided to focus on three main research questions. So firstly, understand how the pandemic has negatively impacted the NTD control activities such as surveillance, MDA, vector control and morbidity management in each country, and document ways in which NTD control activities were changed in order to continue or restart operating during the ongoing pandemic, and specifically focus on any innovative approaches. Finally, given the importance of hand washing in preventing the spread of COVID-19, we wanted to explore whether WASH programs have been strengthened or perhaps repurposed as a result of the pandemic, such as increased funding, and ultimately whether NTDs that are impacted by WASH, such as STH, may benefit. So we designed a qualitative interview guide to address these three topics and plan to conduct interviews with people who coordinated or were in charge of NTD control programs or activities, such as NTD program managers, Ministry of Health staff, or in some settings, a WHO representative. And where possible, also people on the ground, such as community workers, to ensure we had a good range of perspectives from each country. So we've worked with our ACE NTD colleagues and collaborating partners, and also our colleague at the WHO Western Pacific Regional Office to identify a short list of countries to conduct these interviews. And to date, these are the countries that we plan to conduct interviews in. And to date, we've actually successfully completed 3 interviews in 2 countries. So I will now be presenting some of the emerging themes and ideas from these 3 interviews. So many of the impacts of the pandemic that people described were expected. So MDA was stopped, as well as surveillance activities were stopped or paused. So where MDA drugs have been distributed to the community at central points, such as for lymphatic filariasis, this was now deemed a COVID transmission risk. Where MDA drugs were delivered at schools, such as for deworming, this was now not possible due to school closures. Funds and staff that were allocated for NTD activities were diverted to support the COVID response. And we also heard that the drug supply chain had been affected. And also, interestingly, because if ivermectin is being considered as a treatment for COVID, this had actually led to one government delaying its use for NTD programs. So we asked participants what changes were made to their NTD programs to continue delivering the control activities as best they could. In both countries we conducted interviews in, the school-based MDA for soil-transmitted helminths had switched to community-based distribution with different levels of success and different experiences. So it was noted that delivering MDA to children in the community meant that all children between the ages of 1 to 19 had an equal opportunity to receive the drugs. So previously, kids who didn't attend school, or in one country's setting, who attended schools that did not participate in the MDA program, had not previously had access. However, there were some big challenges to delivering the MDA door-to-door, requiring more time and resources, especially when delivering medication in remote areas. And we actually heard how staff were needing to cross rivers and walk huge distances to reach children, which was not practical. And in both countries, they said they would want to return to school-based distribution as soon as possible. So we also asked participants about any changes to their programs that they thought were particularly innovative. And integration was a key phrase we heard a lot. And some key examples included For example, delivering MDA drugs at the same time as delivering food packs or schoolwork to people's homes, or even at the same time as conducting measles and polio vaccinations. And we heard also how parents or caregivers were collecting their child's schoolwork from the school and being given the deworming drugs to take home and give to their child at home. Though it was noted that this modification did mean that drugs were not being taken under direct observation, and that there could also be issues if there were any adverse or severe adverse events experienced. And whilst not actively happening in the country, one participant suggested that surveillance activities could be combined with door-to-door delivery of MDA drugs. So, for example, checking if anyone in the household had symptoms of an NTD or morbidity due to an NTD. In terms of WASH programs, it was difficult to find out much information about how WASH programs have changed as a result of the pandemic from the 3 interviews we conducted. In both countries, WASH programs were managed by a different government department, and it was actually noted that there was limited coordination or integration between WASH and programs to control NTDs impacted by WASH, such as STH. The responses we received suggested there had been an increased resource and funding to health promotion for WASH in the context of preventing COVID transmission. And we hope to learn more from that from subsequent interviews. And finally, it was noted that NTDs have probably benefited by the increased focus on WASH in the pandemic context. Again, something we hope to explore more with more interviews. So in conclusion, I've only conducted 3 interviews so far out of an anticipated 30 or so interviews. So we're just at the start of this project. However, some interesting examples of innovation and change have already emerged, and it will be interesting to see if these approaches are evident in other countries and whether other innovative examples will emerge. So before I go, I'd like to acknowledge our funder, ACE NTD, also colleagues at ACE NTD and Aya Yajima at the WHO Western Pacific Regional Office, who provided guidance in the early days of the project. And I'd like to acknowledge my research group and my boss, Susanna Vasneri, who came up with the idea for the project originally. So thanks very much for listening, and do feel free to reach out if you have any comments or suggestions on this project. Thank you very much.
Thank you, Claire. Great. That was a wonderful presentation. Thanks. So work in progress, and I'm looking forward to seeing what those additional interviews uncover. I like the focus on innovation there and change, right, in the time of a crisis. So let us transition now to our second speaker today, and this is Dubey Alabi, and they're going to be giving a presentation, Impact of COVID-19 on the Experiences and Well-being of NTD Frontline Health Workers in Nigeria. And Dubey Alabi obtained her law degree and practiced law for 3 years before earning a master's degree in international affairs and strategic studies in 2014 from the Nigerian Defense Academy. She ventured into research in 2018 after volunteering for 1 year with the Kaduna State NTD unit in Nigeria. While there, she joined Countdown as a research assistant from 2018 to 2019 before becoming a field coordinator on the case detection study in 2020. So here is her presentation.
The title of my presentation is Exploring the Impacts of COVID-19 on the Experiences and Well-being of NTD Frontline Health Workers and Implementers in Kaduna, Kwara, and Ogun States. We have our co-leads, 8 co-leads based in 3 states, and I have our mentors, Luretla, Oluwatosin Ndike, and Laura Dean. This is the background. The current pandemic has provided worldwide challenges to health system and many NTD services disrupted. And we know that NTD programs are uniquely positioned to respond to COVID-19 with their focus on community-based care and their vital role of frontline health workers. And in this study, frontline health workers include community health workers, such as community drug distributors and primary health facility staff. These are the aims and objectives. We have 3 aims and objectives to explore experiences of frontline health workers and their impact of COVID-19 on their well-being, to identify challenges faced by health workers regarding workload, stigma, and community perceptions during the pandemic, and whether this varies by age, gender, and community. We recommend strategies to support health workers, strengthen them, and help them in managing NTDs in future outbreak. And this is the overview of our project, where we explored 5 steps where participants took 1 to 2 pictures per day, sent them to the research team over a period of 10 days using WhatsApp. And we had FGDs where participants presented their key photos, summarized their meaning, explained why they took it, and what it meant to them. The pictures and findings were developed, produced into a photo booklet, then the findings disseminated through report, photo booklet, and recommendations. This is the photo voice training, where in the 3 states, Kwara, Ogun, and Kaduna, before the photo voice training, the research team were trained virtually on the ethics and process of photo voice, cascaded it down to the frontline health workers, that's the FLHFs and CDDs across the 3 states, and the participants were taught the process of photo voice as a method of data collection, how they can be used to document their experience and well-being, how they should take photos, the ethics, and what is involved in taking photos that are relevant to them. And this is also the pictures of the FGDs after the analysis, after the FGD's data was collected, validated, organized, and summarized according to themes to reflect the experience of the well-being of research participants across the 3 states. And this is the photo booklet, pictures of the 3 states and the researchers and the participants. We have behind the marks, 30 stories on the day in life of a health worker during COVID-19. And after the whole process, we had 12 emerging themes that came out from the FGDs and from the pictures after they've been grouped according to themes. Fears of contracting COVID-19. Health workers were afraid of contracting COVID-19 because they were at the front line, always interacting with patients. People came with different diseases, so they were afraid. Children sometimes run away from them because they were scared also. This is also fear, people cluster together, refusing to observe social distancing. Stigma, they also face stigma from their homes because people tell them to stay away or wash their hands or stay outside for a while because they are afraid that maybe they've contacted COVID-19. And it was disheartening despite their effort as a health worker because of the risk they face to help their community. This is also stigma, the same thing experienced. And we have psychosocial impact where a neighbor of a participant tested positive to COVID-19, and she has a CDD. People didn't want to collect medicines from her because they were afraid. Oh, your neighbor has coronavirus, please stay away, don't give us medicine. Maybe you also have it. This is also psychosocial impact. And challenges in providing routine healthcare was disrupted because people couldn't give immunization. The health workers couldn't give immunization at some point because people didn't want to come to the health facilities. So many vaccines for children were disrupted. It's a sense of responsibility. The CHV showing an example. He feels, okay, I need to wash my hand. Is the facility so that people can see I need to wash my hand, wash it properly, use my nose masks before I go anywhere, before I enter into the facility. There's also sense of responsibility. Added workloads, people are here clustered waiting because of added workloads. Frontline health workers are overburdened, and it's also they face emotional stress. They are stressed physically because of the load of patients waiting. There's lack of resources, there are no resources to work, they don't have enough hand gloves, face masks, sanitizers, so it's difficult to work as a health worker. They don't have light also, lack of resources. And this environmental health due to the lockdown, people were stayed at home, no work, nothing, so everywhere was dirty, dirt had gathered, and it poses a risk to their well-being because this is a dump site and it's not so good to see because it's a health hazard. There's also environmental health, dirty streets. This pride in role. CDD felt she was happy because she could encourage her people. She had go out and give immunization. So she had pride in her role. She was happy as a CDD. This community support where people, the health workers and community leaders came together, supported them, encouraged them in their community, and they were happy about it. There's also community support. Touchlights were given to also assist their community. This is a personal impact. Schools were closed, people going to go to school, so it's so painful. It's also personal impact. A woman couldn't go to church, she was sad, so she had to stream to connect with her pastor to listen. Personal impact, this is a grave, CDD lost her brother during COVID-19 and she was sad about it. This is gender impact. Instead of staying at home, a mother had to tell her daughter to go and learn a skill, learn how to sew to avoid just being idle at home. Food and insecurity, the price of food went high and not everybody could store food. People couldn't afford what they wanted to eat. This is some grain of rice. People couldn't afford what they wanted to eat, so it made them sad because of the lockdown and the price of things skyrocketed. Food and insecurity is also made insecurity to increase. People had to now arm themselves, buy torchlights to be able to guard their community and send criminals away. And we have some recommendations here where were recommended by the health workers: provision of necessary equipment and materials like hand gloves, sanitizers, cotton wool, antiseptics to help ease the work of health workers. Capacity building should be done on a regular basis to aid health workers with updated knowledge and improve their performance. Support for transportation for health workers to help them access their facilities easily. Create a support network for health workers where they can share their experiences and issues affecting them and how to help each other. Continuous health education and awareness on hygiene practices to patients and public even after COVID-19 pandemic. Recruitment of more frontline health workers to ease workload burden, provide remuneration and create income generation opportunities. Thank you very much.
Wonderful. That was a really interesting presentation. Previously, a lot of the studies used observational methods, but now we got a lot of photos and felt like we were there with the CDDs. Great, thank you so much, Dubé. Now we're going to transition to our last and final talk of the workshop, and this is by Adung Gideon Nituen, Determinants of Willingness to Work Among Neglected Tropical Diseases Program Implementers During Health Shocks in Nigeria. Uduak is a program officer with the National Schistosomiasis and Soil Helminthiasis Elimination Program in Nigeria. In addition, he serves as a focal person for the Nigerian Human African Trypanosomiasis Program, lead for ensuring that Nigeria remains guinea worm disease free. He's also a representative of the National NTD Coordination Committee for the Countdown Project in Nigeria. So let's hear his final presentation.
Thank you for the opportunity to present findings from our study, which is one of the Countdown COVID-19 Rapid Research Fellowship Studies in Nigeria. The study is titled Determinants of Willingness to Work Among NTD Implementers During Health Shock, Case of Implementers in Ogun State During COVID-19 Pandemic. Introduction. COVID-19 pandemic has resuscitated an important question on how to make health systems sufficiently resilient to manage health shocks. By way of clarification, a health shock is seen as episodic and unpredictable illness capable of diminishing the health status of a given population and affect the supply of health workforce. At the heart of health system are health workforce, a most critical resource during health shocks. The pandemic did not only put a stop on major NTD interventions, but also affected the delivery of NTD services at health facility level. This led to calls for local authorities to continue to support NTD prompt diagnosis, treatment, and care during the pandemic, and to use existing NTD platform to support COVID-19 measures. This saw the involvement of NTD implementers in COVID-19 response globally, and this is also the case in Ogun State, Nigeria. However, the capacity of implementers to continue to deliver safe and quality NTD services within the context of the pandemic, like COVID-19, could be challenging. This is due to concerns about their safety, given that they are also susceptible to the risk of infections, both of themselves and their family, which may lead to decisions to stay away from work. So understanding the willingness of NTD workforce to deliver interventions during health shocks like COVID-19 is therefore pertinent. The study then sets to explore the knowledge and attitude of NTD implementers towards COVID-19 pandemic. Identify factors responsible for implementers' willingness to work to deliver NTD services during pandemic. Methods. A cross-sectional study happened across 2 locations in Ogun State, Abeokuta South and Odeda local government area. That's a rural urban context. We targeted CDDs to deliver mass administrative medicine at community level and took part in hygiene promotion campaign as part of COVID-19 response. Health workers who provide clinical and non-clinical treatment to patients presenting at health facilities. We randomly selected 10 health facilities and sampled 10 CDDs per health center and purposefully sampled 3 health workers per health center. Overall, 260 NTD implementers took part in the study. Outcome. There were 3 outcome variables: knowledge of COVID-19 pandemic, attitude to COVID-19, and willingness to work during COVID-19. Knowledge of COVID-19 was assessed during questions that included information about disease prevention, control measures, and how to deliver NTD services during COVID-19. In the same way, attitude towards COVID-19 made up of questions that include information on worrying about suffering from COVID-19, confidence of government response, and the use of preventive measures. For willingness to work, we have 22 structured questions to measure willingness that included information related to risk of infecting self, family members, early coordinated response, duties not trained for, disruption of children's services, working with untrained volunteers, when colleagues are dying, risks of infections during work, working overtime, disruption of transport. With the outbreak of COVID-19, we try to find out what will make implementers more willing to work. This includes availability of vaccines for them and their family members, provision of transport to and fro work, provision of PPEs with antiviral drugs, supplemental hazard allowance that is commensurate, and life/disability insurance, working flexible hours. Findings: knowledge of implementers about COVID-19. Overall, 85.7% of the implementers were knowledgeable about COVID-19 pandemic and how to deliver NTD services during pandemic. However, only 8.6% of CDDs and 7.4% of health workers had experience delivering NTD services during health shock in the past, like people that were involved in Ebola pandemic. Majority of implementers stated that they have received training on COVID-19 prevention and control measures. CDDs had 88.6%, while health workers had 92.8%. All implementers understood the risk of COVID-19 for themselves and others. CDD 96% and health workers 96.4%. attitude of implementers about COVID-19. Overall, 80.2% of implementers have positive attitude towards COVID-19 pandemic. On the average, only 36 of the implementers worry less about suffering from COVID-19. And this is higher among health workers than the CDDs. CDDs had, we got 37.4%, while health workers, 38.5%. Confidence about government initial response plan to pandemic is higher among CDDs than health workers. CDDs 91.9% and health workers 83.1%. More than 90% of implementers agree to use PPEs, agree that the use of PPEs will protect them, will protect NTD implementers from COVID-19 pandemic. CDDs 90.9% and health workers 94%. On the average, 73.4% of implementers agree that PPE did not interfere with patients' treatment during COVID-19 pandemic. CDDs 67.5% and health workers 79.3%. Willingness to work. Overall, approximately 40% of the implement services during pandemic. Proportion of willingness to work is higher among CDDs, 42.7%, 47.2% than among health workers, that's 6.1%. Between 23 to 34% of implementers were unwilling to work due to risks of infecting family, dying colleagues, children, siblings falling sick, risks of self-infection, and working on duties not trained for. Willingness to work is influenced the most. Willingness to work is influenced the most, 97.3%, by coordinated response to the pandemic by health authorities. Compared to those with no child care responsibilities. Implementers with elderly care dependent are 1.8 times more likely to work than those without elderly care responsibilities. Those who do not worry about suffering from COVID-19 are 1.02 times more likely to work than those who worry very much about suffering from COVID-19. Implementers who understood the risk of COVID-19 are 1.4 times more likely to work during pandemic than those who do not understand the risk of COVID-19. Takeaway message. There is need to increase the knowledge about pandemic and how to deliver NTD services during pandemic among implementers. Sustain structured training for implementers on how to deliver NTD services in the context of a pandemic, since majority do not have experience working during pandemic. To minimize the risk of infection among implementers, proper assessment of health shock should be done prior to deployment of implementers to protect older implementers and their dependents. The health system early coordinated response to the pandemic is necessary. It is necessary for implementers to be confident and willing to work during pandemic. Interventions such as provision of transport, PPEs, antiviral drugs, commensurate hazard allowance, disability allowance, and flexible working hours to reduce absenteeism from work during pandemic. Closing, no implementer should be infected or even lose their life trying to deliver NTD services during any health shock whatsoever. It behoves on the NTD community to ensure that proper risk assessment is conducted before repurposing implementers to respond to any health shock. Thank you for your attention and for the opportunity.
Wonderful. Thank you very much, Aduak, for that great presentation. I'd like to invite the three speakers to join us here, their video. Great, nice to see everyone. Thank you for your presentations. I'd like to start here. We have a couple of questions in the chat box, and I'd also encourage everyone to post additional questions if you have any. And well, actually, before starting, I'd just like to mention that Alice Sonket, who gave a presentation on the last session, she wasn't able to join us. But if anybody has any questions for her, this is the presentation from Kenya. She encourages you to email her, so please do that. Okay, great. So thanks for that. Interesting presentations on willingness to work, the use of photo voice, and then sort of a broader policy analysis or sort of a cross-sectional study around different, involving different country teams, etc. I'd like to just start with a question for Dupe on the use of photo voice, and this is from Beth Long. She's asking about specifically around stigma. So she asks, the CDDs reported being stigmatized due to the use of masks, and she's wondering, were there any reports of being fearful or unwilling to participate in future campaigns, right? So this gets to the issue of, okay, the experience of CDDs during the COVID-19 pandemic, and if that's led to, an increase in dropouts or unwillingness to work in the future. What do you think, Dupi?
Okay, thank you very much for the question. Yes, they've mentioned stigmatized, but they didn't mention not willing to work in future campaigns. They just wanted maybe some better working conditions, but on their willingness to work in future campaigns, no, they didn't say they wouldn't do that. They were willing actually to work in future campaigns, and enthusiastic that if future campaigns come up, they can do it. Just some better working conditions to reduce the impact of what they experienced and what they faced during the pandemic. Yes, thank you.
And did you find that, I mean, the notion of stigma, right? I mean, stigma is a very complicated phenomenon. And I'm wondering, was this seen as an issue in terms of, during the MDA itself when CDDs were visiting, or did they find some problems in their own community because they're engaging in this work? People might think of them as moving around so much and going to sick people's homes, and there might be some tension in the neighborhood. And that actually relates to a larger question I wanted to ask yourself, but also Uduak as well. In terms of the CDDs, I would imagine that many of them could also have been involved in COVID-19 outreach activities and other health programs, right? So they're not just necessarily doing MDA. And so, this perception of stigma might be related to their broader role in the community. So yeah, I just wanted to.
Yes, a lot of them were involved in the COVID-19 outreach. But the perception they had, since a lot of them didn't actually, from Ogun State, initially a lot of them didn't actually come across any positive case. So they participated fully in the MDA because they didn't lay hands on, they didn't actually see a real positive case that will convince or discourage them from working. So they're just out there to work. And some of them being their notion that they are helping their people. So they participated fully. So it wasn't them to them. There was no stigmatization, nothing about them. They were just working like that.
How about yourself, Dube? What do you think?
Yeah, okay, mostly it's from the community and from the community members, because they felt they've been going to sick people's homes, being called upon when there's an issue, or people visiting the facility. They felt, okay, when you now move around in the community, people think you already have COVID-19. So they're a little bit stigmatized. Before they enter into their houses, people say, no, please don't touch that. Go outside, wait out to wash your hands. In fact, one health worker reported it was in the night and she wasn't allowed to enter her home because her family members felt, oh, no, you stayed out with sick people for so long. Please stay out for a while. So that stigma they face from even their own family members and some of the community members, was actually a team that came out in the 3 states where we conducted the study.
That's a major issue, right? Okay. So did you also find that CDDs were working in the COVID response, or they had other roles that they were involved in, or?
Yeah, they had other roles they were involved in, mostly in the facilities. Though they didn't mention any positive case, but just they had other roles as working in the facilities and working in their communities as community distributors and in the facilities. Other roles, other duties they performed while doing their job, actually.
Great. And I mean, the use of photo voice is a really interesting method, and we really appreciated the photos there. And I mean, it's very rich data, right? Did you find that challenging to organize in the context of the pandemic, or did people were very receptive and interested in that methodology?
Yeah, it was okay. It was not so challenging, just few challenges, because it was actually a new method to almost every of the participants, because they're used to the usual, okay, focus group discussions, semi-structured interviews, or participant observation. So when we came about, okay, this is what we're going to do. We're going to record it. And then it was in the middle of the pandemic, you know, we wouldn't have to see. So we had to bring up the idea of sending your photos through WhatsApp. And what we'll do, yes, we know there'll be challenge of, okay, I don't have finance for data. We have to make provisions for that for them. So I give you data, and then you send photos to us, take photos. And while we did the training, the day we did the training, we had to make sure, okay, go outside and take any photos just in the middle of the training, take photos and come and tell us what you think about it. And after they took it, they found that, wow, it was quite interesting. In fact, from the second day, photos started coming in. People were quite surprised. Wow, this is quite interesting. I just take photos and send recordings of what. So it was quite an interesting. They really enjoyed it. It was an interesting method, actually, and that's how we would do that during the pandemic. Send it via WhatsApp or a small caption, a recording, tell us what it meant to you, and it was quite good.
I think it's a brilliant approach. I really enjoyed your presentation. It was very different to other approaches.
Thank you very much.
Yeah, you could envision that being used in the future. So alongside the observational work, or even instead of it, right? Having CDDs taking photos as they're going along, doing distribution, and then sending them to the manager, etc. Right? I mean, some programs have WhatsApp groups, and they're very active. So that's great. A question for you, Claire. Just you're still getting started here.
Yes.
And I mean, these comparative studies are really interesting and important, right? They can also be challenging depending on also like where the pandemic is, right, in each of those countries, because actually the MDA programs, like we've seen, they're really influenced by what's occurring at the moment, right, in terms of the epidemic curve or et cetera. So just wondering how you came to select those 3 countries specifically the Philippines, Papua New Guinea, Cambodia. If there was any sort of logic to that, or if it was more opportunistic.
Yeah, I mean, there was a method in the madness. So we sort of narrowed down, well, we worked with our colleagues who have projects ongoing in those countries to sort of get their advice on perhaps whether they'd heard any examples of innovation, whether they were aware of any particular challenges to NTD control programs, specifically MDA, which, as everyone knows, was stopped by the WHO directive last year. So we sort of started off with a list, a sort of short list, and then we've gradually narrowed that down. So I've had a number of preliminary discussions with key contacts in the country. As you mentioned, the pandemic has obviously affected countries very differently, and it's been interesting to hear. So one country has actually not had any community cases, and yet they've still been they've still experienced quite severe restrictions and lockdowns because the government was so worried about the possibility of COVID. So yeah, so as I said, it was a sort of short list. It was governed a little bit by where we had contacts. And as the project has been progressing, the irony is that the project is being delayed by COVID itself. So we've had to we've had to put in ethics applications to each individual country, and that is taking some time because of resource limitations because of the pandemic ongoing in the country. I'm not sure I totally answered your question.
No, I think you did. And so actually I have a second question for you from somebody in the audience here. So they're asking, Claire, okay, you mentioned that integration was identified as a key adaptation by programs. Is integration something that was already a priority for these programs before the pandemic, or was this purely an adaptation made out of necessity? Did the stakeholders see this as something that will remain a priority after the pandemic?
Yeah, that's a really good question. And I mean, I think like if you look at some of the policy directives from WHO, for example, integration is something that I think NTD programs have been driving at for a very, very long time. And so I think to answer your question, so where I've said integration is a key theme, I think my sense from the few interviews I've done is that it's been something that has been high on the priority list for a long time, and that the pandemic has forced an acceleration in that integration. And I mean, integration has taken a number of different forms. So it can be, NTD programs working with other NTD programs. We've also heard anecdotally about NTD programs joining forces with other health programs. I mean, I mentioned, for example, delivery of MDA and food packs, so nutrition and MDA, and then the sort of innovative approach and sort of integrating with education. And we heard about school teachers delivering homework and MDA drugs at home. So I think integration has been something that has like we've been trying to sort of force it to happen, and it has come about more because of the pandemic. And the sense I get from the 3 interviews we've done is that it's something that they're pleased that the integration is happening, and some of the integration examples will continue after the pandemic.
And that's great. And so for you, Aduak and Dupaid, have you seen any examples of integration or adaptation due to COVID?
Well, if I might come in, integration has been part of our NTD program. Like when Nigeria had a guinea worm, we had integration with the immunization program to write home the way if you go for immunization, in the immunization card, we had a photograph of a guinea worm. You asked, do you have this here? That helped us to eliminate guinea worm in Nigeria. Even in the National Schistosomiasis program, we have integration with the school home feeding program. It's the humanitarian program of the government where they feed children in the school. So we have integration with them. So where they are doing this, we can administer praziquantel when they feed very well. So the integration has been part and parcel of NTD program. Like we have links with the Ministry of Education, Federal Ministry of Water Resources for our WASH. So the integration program has been on. And COVID-19 thing has also solidified this integration program. I think with this, the integration continues.
It sounds like you're doing really well, Udak, in that integration. And have you seen any changes in WASH programs? Because that was something that integration seemed very poor between Department of Health and the departments that manage WASH, like very little integration there.
Yes, the COVID-19 has really enforced the WASH program, like washing of hands. That has made, if you go to a lot of places now, you see buckets of water in hotels, schools, you see a lot of people washing hands, and with that, they can even wash their face. It has really affected the NTD program. Like that has helped to also reduce trachoma, and it has enhanced the WASH program in Nigeria since the COVID-19 came up.
That's because that's one of our hypotheses that we're sort of hoping to document, because it's, you know, something, it makes sense. I mean, as you've just said, reducing trachoma if people are washing their faces more. So that's, it sounds like I should be interviewing you. Unfortunately, we're focusing on the Asia Pacific region, but no, it sounds like you've got some really interesting examples there.
Yeah. Really, the COVID-19 has really helped our WASH program. That has also made the WASH program to come up in most of our activities now. The WASH component is enhanced, like the NTD master plan that is being reviewed now. The WASH component is being strengthened. We had our colleagues from the Ministry of Water Resources coming up so that they can have a robust collaboration. So we have a more purposeful WASH program attached to the NTD.
Wow. That's amazing.
How about yourself, Dupe? Have you also seen examples of integration in your study sites?
Yes, in my study, not particularly my study, but a study where I'm the school coordinator, the case detection study on the calm down in Nigeria. We actually do, in fact, the basis of our study is integration, where we're trying to integrate 4 key entities together. Borrelia ulcer, hydrocele, leprosy, and lymphedema. So we are talking of integration where we can come together. Though just as Gideon said, integration is in process, but we can strengthen it where we now have a strengthened, and then we can bridge that gap. That gap there, there's a gap there, so we can bridge the gap and see how these diseases can be integrated, and then we strengthen the system so affected people having key entities can have access to treatment easily.
Okay, well, I think that's a good place to end here. Okay, so I think we're running out of time, and I'd like to just thank all of the speakers from the first and also the second session here. And I think I would encourage everyone to get in, if we have further questions, get in touch with each other through email and keep the conversation going. So thanks so much for this interesting, wonderful workshop, and for participating. And I look forward to connecting with all of you sometime in the future. Thanks, everyone.
Thank you.
Thank you.
And I think we're just going to now pass it quickly to Angela Weaver with Don Keller to offer some closing thoughts on behalf of NTD.
Thanks, Lee. Get in here before everyone jumps off. And thanks, Kevin. My regards to all who remain with us. I will be brief. This has been such a rich webinar with excellent presentations, participation, and discussion, too much to try to summarize. So I'll just thank all the presenters and those who have contributed. I'd like to close out today by reflecting briefly on something LaShawn Benedict from ICORDS mentioned earlier in the webinar, the importance of communities of practice. Communities of practice in general have the potential to enrich our work through the sharing of information, lessons learned, best practices. This is especially the case in an environment full of unpredictability and ongoing and emerging challenges, which is the exact environment we continue to find ourselves in with the COVID pandemic. When Simon Bush, my co-chair, and I proposed the NNN working group on COVID in the first few months of the pandemic, we anticipated there would be a need within our NTD community to rapidly share experiences and best practices, especially as countries began to restart and implement field activities. The global situation was changing weekly, and within countries, the status of borders, transportation, mandates, and other measures were also changing rapidly, if not daily. We also anticipated that this would be a shorter term working group. We were wrong about that last bit. Unfortunately, the pandemic persists, and so does the need for the working group. We will likely now be implementing second and third rounds of MDA and other NTD interventions during COVID, and we will undoubtedly continue to face challenges and setbacks. Today's webinar is a great example of how vital it is that we come together to share experiences and learn from one another. This is essential if we are to effectively adapt programs to the challenges COVID poses, so that we can continue to reach those in need of NTD interventions. This community has worked so hard to get NTDs on the global agenda and on national agendas, and we must keep it there, even as other health priorities such as COVID emerge. I would like to thank Simon Bush, my co-chair, and all the members of the NNN COVID working group and sub-working groups led by Maggie Baker and Phil Downs. I think Simon would agree with me that we've achieved more than we expected. I'd also like to thank Core NTD, especially Lee, and also Beth Long for this tremendous collaboration. And I congratulate you on this highly successful Research Links series. I'll now turn it back to MYT to close the meeting. Thank you very much and stay safe.